expert out here. Thereafter, Dr. Ramaraju will be presenting his first presentation. And then Dr. Mittal will take over for case study discussion. And for the case study, then she will ask you and Dr. Ramaraju alternately how you will manage the cases for each of the cases. So you can provide your views on that. And then at the end, we have a question answer session. So all people who are logged on, they can ask questions live, and we will be what I'll be doing is that if the question is addressed to a particular expert, I'll ask an expert to answer, or I'll randomly ask anyone, and then all three can contribute to that question, answering the question.
Hello, Mr. How are you?
I've seen you, Janita.
Oh, okay. Yeah, nice. You want to take a seat? Yeah, please take a seat. Dr. Prinka Ali, she's there.
She's seeing on VPN.
Okay. All right. So my screen is live now.
Yes, doctor. And we are live also. So whenever we are ready, we can start the session.
Okay. Okay, it's in the screen. No, it's okay. Now it's already live. So we just 7 o'clock was the time. I think so. Do you have participants out there who are already logged in?
Now we cannot refresh the server right now, but in meanwhile, I can just refresh it. It's just started. It will take load for the server then. I'll keep you updated, Dr. Pag.
The other guy who's talking.
So when sir would be giving his talk, would we be seen, or we will be, when Dr. Ramaraju would be giving his talk?
No. So what you can do, ma'am, and Dr. Gunishila and Dr. Mittal, is during that time you can mute your audio and your video.
Correct. No, not required the video. You can just mute your audio. That's it.
Yeah, that's it.
You keep the video active.
If you don't want to be seen, then mute your video also. But then again, you can switch it on later.
Better to just switch off the audio, so at least there will be a presence for the audio, and these doctors also as a panel, so that will be also visible to them.
If I press mute, then I'm not heard.
Yes. Yeah.
Mute Ali.
So we are live, so let me know when can we start. You can go ahead, Dr. Pavitra, whenever you are ready.
Pavitra, let me know before you go live.
So we are already live now.
Okay.
We are live now.
That symbol will come when he is muting. No? Then other people are talking. If you mute, we can hear. Disturbance will be there.
Okay, fine. You want me to mute now?
No need. You can ask Pavitra. Pavitra, is it necessary?
So what I will do is, when I am presenting, I'll just mute, or you can mute from your end, madam. Dr. Gunishal, you can mute from your end.
Okay.
Yeah. And then during the discussion, when it's needed, then we can again come online. So
I'll mute right now, okay?
Yes, ma'am. You mute right now till Dr. Ramaraju's presentation is over.
Yeah, okay.
We mute the audio.
Mute the audio. So it's 3 minutes now. After 3 minutes, I think so we can. Yeah.
Pavitra, how long does it go on for?
It will go on at least for an hour.
For an hour.
More based on the questions, because there'll be question answers. So if the question answers, then it can go on for a little bit more than over an hour.
Be prepared to skip your dinners.
Okay. No, I've had and come, so I don't skip anything. Hence the size.
So, ma'am, we'll begin now. I think so. We'll begin. It's 7, so I think we should start on time. Then we'll just begin. So, a very good evening. I am Dr. Pavitra Devda from the Medical Affairs team at Merck, and on behalf of Merck, I would like to welcome all of you all to this scientific webinar on management of low prognosis patients. At Merck, it's our endeavor to bring you the latest and the best in the management of fertility. And in line with this, we are presenting you this seminar. It's a first of its kind seminar in the form of a webinar where experts are directly there face to face and addressing not only the important queries that you'll have, but also talking about the latest developments in the field of ART. This program is accredited by the Maharashtra Medical Council, and on completion of this program, that is from end to end, you'll get 1 credit point as a certificate. So the program is designed in terms of being very engaging. So we have a talk by Dr. Ramaraju on the management of low prognosis patient, focusing on Poseidon group 1 and 2. Thereafter, there'll be case discussion studies on low prognosis patients by Dr. Mittal, which will be then taken on with a question answer session by Dr. Gunishila, Dr. Ramaraju, and Dr. Shweta Mittal herself. So to introduce the experts for today's meeting are Dr. Ramaraju, Dr. Devika Gunishila, and Dr. Shweta Mittal. Dr. Ramaraju is the founder and director of Krishna IVF Clinic at Visakhapatnam, which is the first IVF clinic in the district of coastal Andhra Pradesh and Orissa. He has completed his graduation from Andhra Medical College and post-graduation from the National Board of Examination in India. He received his training in ultrasound and endoscopy and assisted reproduction at Wadia Maternity Hospital, Mumbai, and the Kiel University in Germany, respectively. He's also specialized in ICSI, TESA, and assisted hatching from the Bielefeld Institute in Germany. Currently, he's also the adjunct professor at the Department of Reproductive Medicine at Sri Ramchandra Medical University in Chennai. He's a visiting professor at the University of Gießen, Germany. He's a PhD guide at the Department of Human Genetics in Andhra University, investigator for the Samsung Korea, and also on the advisory board for Merck India and the APAC region. Today, Krishna IVF Center, which was founded by Dr. Ramaraju, is an extramural research center for research for Andhra University and offers mentorship programs to interact, teach, and share knowledge in the field of reproductive medicine. Till date, the center has mentored over 300 gynecologists from across India. Dr. Ramaraju received the Merit Certificate Honorary Secretary, India Red Cross Society by the Honorable Governor and the Samakhya Bharat Gaurav Sanskar by the Delhi Telugu Academy. In 2008, he was awarded the Gold and Silver Medal for motivation of blood donors by the Indian Red Cross Society. He has extensive research publication, has authored 3 textbooks and 21 publications. He has a citation of 601 from 24 articles in various fields of reproductive medicine. He's a regular speaker at national and international congresses, and he's the organizer of the Focus Annual Conference in Visakhapatnam that happens on a yearly basis. So thank you, sir, for being with us today. Our next expert is Dr. Devika Gunishila. Dr. Gunishila has qualified in 1994 from Bangalore Medical College and is managing partner of the Gunishila Surgical and Maternity Hospital and the Gunishila IVF Center in Bangalore. She was in UK from 1994 to 2000, where she completed a post-graduation and got the membership of Royal College of Obstetrics and Gynecology in London. She came back to India in 2000 and completed a fellowship in reproductive medicine in 2005. She's a specialist in infertility medicine, recurrent pregnancy loss, and in vitro maturation. She has, to her credit, many presentations in national and international conferences. She has written plenty of articles in newspapers and co-authored many chapters for books. Dr. Gunishila is taking the institute forward in the realm of in vitro maturation, of mature oocytes and fertility preservation in young cancer survivors by building a team of consultants consisting of surgeons, physicians, and radiotherapists. involved in the treatment of cancer in Bangalore, to create awareness among the medical practitioners who should be aware of the existing of such a facility in the general public. So we thank Dr. Guneshila for being with her today evening. We also have with us Dr. Shweta Mittal. She's a senior consultant at the Center of IVF and Human Reproduction, Sir Gangaram Hospital, credited for the first pregnancy from frozen thawed oocytes in North India. She's the first fellow from the National Board of Examination in Reproductive Medicine. She's a teacher to DNB and FNB students with over 300 national and international presentation and publication. She's also the reviewer of Journal of Assisted Reproduction and Genetics, Journal of Obstetrics and Gynecology of India. Recipient of the MCE Young Scientist Award and the Vigyan Vardhan Award, Foxy Ethicon Traveling Fellowship, Dr. Mittal has contributed a lot in the field of ART. So thank you, Dr. Mittal, for being with us. And for the delegates, please note that below the screen, there is a link for your feedback. So at the end of the session, please do give your feedback. It's very valuable for us to organize such meetings in the future. And as a disclaimer, please note that the views expressed in the presentations following are of the IVF specialist and the clinicians themselves. So with that, I would like to invite our first speaker for the day, Dr. Ramaraju, for taking us through the management of low prognosis patient with focus on Poseidon Group 1 and 2.
Yes.
So you can switch over to the presenter view. This is the presenter view. You can switch over to the.
Yes. You're able to see that clearly?
Able to see it clearly.
I can start my presentation.
Yes, sir. You can start your presentation.
Good evening, everybody, and a warm welcome to the web seminar, which is one of the first of its kind in India. And the Merck has come forward to help us to share our knowledge from vast distances across the Indian subcontinent. And I, along with my colleagues, Dr. Shweta Mittal and Dr. Guneshila, we like to do whatever we can do to our best of our ability to help you understand and share some of our experiences in the area of low prognosis patients, and particularly in the role of Poseidon Group 1 and 2. In this endeavor, we'll be taking you through a journey in which I'll be basically in the first 30 minutes speaking about the concept of poor responder, the Bologna criteria, the Poseidon strategy, the role of LH in early follicular phase, the role of LH in the mid follicular phase, the LH window concept, LH in the control ovarian stimulation, and concept of LH supplementation in hyperresponders, and the role of LH polymorphism. It looks like a lot, but when in reality, at the end of the lectures, you find simple carry-home messages which will be very useful for you in your day-to-day practice. Why should we be concerned about the number of oocytes that are present in any given cycle? One important statement that is made but seldom taught to us in any of our conferences is 100 oocytes will give a pregnancy rate of 6.6 to 7 babies. That means the number of oocytes makes a lot of difference in the outcome of any unit. So the emphasis is the adequate number of oocytes so that the inefficiencies of fertilization, the inefficiencies of the cell division as it progresses from the fertilization to the blastocyst, where a significant amount are lost, and then selection of those embryos, and then transferring them into implantation. Unless we have adequate numbers, we won't be able to give an adequate carry-home baby rate per cycle in a given woman. So when we are speaking about a poor responder or a hyper-responder, we are speaking about a single cycle and an optimization of pregnancy rate in this situation. Ovarian responses can be divided into three groups, that is the poor response, the optimal response, and the high response. In 2011, for the first time, people were able to subgroup the poor responder from low responder and saying that people who have less than 3 oocytes might be poor responder. Subsequently, the optimal responders were again subdivided into two groups. The optimal responders are the people with between 4 to 15 oocytes, which were again subdivided into 4 to 9 oocytes, which are called the hyper-responder, and the 9 to 15 oocytes, which is the optimal responder. And the third group, which we have, is the more than 15 oocytes. So essentially, the number of oocytes will determine the outcome, but also determine the success rate of a cycle and the failure rate and the cost economics, and also if you're producing over response, the possible complications and the consequences for the woman. So the stimulation protocols involve a lot of responsibility on our part to identify the low responder, the suboptimal responder or the hyper responder, the optimal responder, and the good responder. It's our responsibility to check this information before we start a cycle. When we speak about low or hyper responders, we hear about two words, that's the Bologna criteria and the Poseidon concept. What are they? The Bologna criteria started in 2011 and the Poseidon concept started in 2015. What is Bologna criteria? It's the name of a city in Italy, wherein, like the Rotterdam criteria or consensus statement you have in the polycystic syndrome, this meeting was held in Bologna and hence it carries the name of the city. And this meeting was conducted by the ESHRE, in which they wanted to identify the subgroups of people who have low response so that future research can be channelized into a well-defined pattern like the polycystic ovary. In the Bologna criteria, there are essentially three major groups. One is the advanced maternal age or people having risk factors for poor ovarian response. The second is a patient who already had a cycle with standard stimulation, not any stimulation, where she obtained 3 oocytes. And the third group is where your antral follicles are between 5 and 7, or the AMH is between 0.5 to 1.1 nanograms per ml. In these 3 criteria, at least 2 should be there of the 3 criteria to show that these women are poor ovarian responder or Bologna criteria. After 2011, there was no further development in this area. Hence, there was some amount of criticism as progress has made that Bologna criteria has taken only women above 40 years and not taken below them. It did not add or update the information about the risk factors of poor ovarian response as technological advances and knowledge has come in the last 6 years, that is between 2011 and 2017. And one major deficiency was no clear management strategies were advocated in these criteria. To overcome these deficiencies, a group of scientists from Europe have come up with the concept of the Poseidon concept. These people are eminent reproductive medicine professors from Europe, predominantly from Europe, and one from South America, that's the Brazil, who have sat together and analyzed the information and came with a statement called the Poseidian concept. The meaning of Poseidian concept is patient-oriented strategies encompassing individualized oocyte number. That means they have criteria these groups into subdivisions so that it becomes easy for us to manage and to counsel the patient into the following subgroups, which I'll be showing you in the next slide. They divided these groups into essentially 4 groups: Group 1, Group 2, Group 3, and Group 4. If you look at closely, the Group 1 and the Group 2 are people who have good AMH, good antral follicle count, but were giving less number of follicles. Whereas in the Group 3 are where they do not have good few antral follicles, low AMH, and the Group 4 are the patients who are elderly and also has low ovarian responses. The main area which we are trying to address today are the Group 1 and the Group 2, and how to optimize them to get good number of oocytes so that we have a better carry home baby rate. At the same time, not to shift to oocyte donation just because she had a bad response one time. Before we further move into that, all of us are taught for many years LH is bad, and LH, if it is higher, it has bad thing. But when you look at this slide, LH has a concept called a threshold, a normal level, and a ceiling level. What we fail to understand most of the time is all 3 are not present in the same patient. So a threshold will be there in a lower responder groups. A ceiling will be there in the higher responder groups. So one should understand that all 3 will never be present in a single patient. Any 2, that is an optimal responder or a lower threshold, will be there, or an optimal responder and a higher threshold. This one should remember, and when you look at the data about the role of LH in the menstrual cycle, it can be divided into 3 groups: at the follicular phase, at the mid-cycle phase, and at the luteal phase. In the follicular phase, it promotes androgen secretion from the theca cells, which becomes the main feeder for the granular cell to produce estrogen. And as the follicle undergoes dominance and the FSH starts decreasing, the LH supports it. That's the role in the follicular phase. In the mid-cycle phase, in the black box which you see, the LH plays a major role in the resumption of meiosis, maturation of the cumulus oocyte complexes, follicular rupture, and granular cell luteinization. And the third is the most important, which is evolving for future, is maintenance of corpus luteum, which all of us know. Newer information coming in for the role of endometrial receptivity and implantation. And further, recruitment of new pool of follicles. So the role of LH, what we understood a decade back, is changing and becoming a more refined theory. When you look at the 2-cell 2-gonadotropin concept of steroidogenesis, we only knew that effect of LH on theca cell is androgen production, or effect of FSH on the granular cell is for estradiol secretion. But after the advent of genomic information, this concept is undergoing a major transformation, as you see in the next slide. In this slide, the 2-cell 2-gonadotropin treatment being revisited with the addition of LH receptor concept to various phases of the follicular development. Initially, it was thought LH receptors are present only in the theca cell, but now new evidence is showing that it is present in the granular cell, and this will help to drive the follicular maturation and the development of the follicle and the lesser apoptotic activity. So in conclusion, the current concepts are, earlier it was thought LH receptors are present only in theca cell, but not in granular cell. But more information and proof has come in, which this proof is as old as 25 to 40 years old. Only thing is, since we did not understand genomics, we could not comprehend this information. To recapitulate what happens when the role of LH in the first phase of the cycle is, it affects the androgens, in turn alters the FSH receptors in the granular cell, and in synergetic action increase the estrogens and also increase the recruitability of the antral follicles. But when it comes to mid-follicular phase, when LH receptors start forming on the granular cell, steroidogenesis continues, the maintenance of the FSH-dependent aromatase activity happens, and also regulation of final oocyte maturity happens. So whenever one is doing a stimulation protocol, going back to the basics and re-understanding that LH has an important role, and that role is evolving as people are aging into an older age. 10 years back, the age of the patient we saw in an IVF clinic were in their 25s and 30s. Now we see women in their 35s and 37s. And as the woman ages, the role of LH becomes much more important in the management to get optimal number of oocytes. Here, I just wanted to show how LH changes throughout the cycle. Here in the yellow line, which you're seeing the hypo-hypo. Then the blue line, which you're seeing an antagonist cycle. Irrespective whether you give an antagonist or not, with time the LH decreases. The green line is for the agonistic cycle, and the red line is the natural cycle. LH decreases till it undergoes the surge, and this has major implications in the follicular dominance. A recent publication which showed that the amount of LH that decreases in an antagonon cycle also happens much before the antagonon happens. So blindly starting antagon cycle for every patient, even though it's important for preventing luteinization, the role of supplementation also plays a role in antagonistic cycle. Lot of people think LH supplementation role is there only in an agonistic cycle, but does not happen in an antagonistic cycle. That has been partly disproved by this study, wherein they looked at on the axis you have the percentage, then as the number of times the LH decreases, the pregnancy rate is coming down. So understanding the concept of LH supplementation, even in antagonistic cycle, is equally important. Before we go to the next component, I would like to speak a few minutes on LH stimulation. The LH threshold is different from the ceiling effect. When you see elevated LH effects, most of these publications were there when the average woman in the clinics were in the 25s or in the 30s. But when you look at suppressed LH levels, most of the publications that you see on these things, when you look at the years in which they are published, by the time the average age of the women or the population have moved to 35. So as women ages, you have low LH levels. At younger women, you have high LH. So whenever somebody speaks about threshold and the ceiling effect, always look at what is the age population they're speaking in. Are they speaking about older women or younger women? That makes us to have a better interpretation. If the threshold is not reached, you have impaired follicular growth, inadequate androgens, and oocyte maturation is compromised. When the ceiling is there, suppression of granular cell, which we are seeing less often because the average patients which we are seeing today has moved from 25 to 35. That's the population most of us are seeing. So the optimal level of LH that should be there should be more than 1.2. Should be more than 1.2 and less than 5. That is the concept of therapeutic window. In the next slide, I wanted to show a video which was provided with courtesy from the Merck, which beautifully shows us the difference between LH and HCG, in which both of them act on the same receptor, but they are different molecules. They are of different sizes, they come from different sources, and their half-lives are different. The mechanism of action of HCG and LH is also different. And when they act on the cell, the area wherein they act the cell are again totally different. LH acts through ERK pathway and HCG acts through the cyclical AMP pathway. Ultimately, for an average patient who's healthy and young, whether use LH or HCG at appropriate doses should not make a difference. But when you're looking at difficult patients, using the best possible product which has anti-apoptotic action makes logical sense. What is the concept of hyperresponder? In a poor responder, you'll have this many follicles, and whatever you do, whether you give growth hormone, LH, or whatever it is, you only get this number of follicles. You can't get anything more outside from thin air. So one should always remember, in a poor responder, if you define them properly, you get only few oocytes. But that is different from a hyperresponder. A hyperresponder patient has a good prognosis. A poor responder patient has a lower prognosis. This is the key message of the whole meeting. Hyperresponders have good prognosis, and when you stimulate a hyperresponder, if you get less number of eggs, there is a scope for correction. That is where the concept of Poseidon concept is coming in, wherein in group 1 and group 2 patients, with adequate dose of stimulation, when we say adequate dose of stimulation of FSH, did you take into consideration the role of BMI when you gave the dosage, the age of the patient, the antral follicle count, and in that patients, after giving adequate dosage, if your rate of follicular growth is not proper, but the follicles are seen, but they are not progressing at the rate of 1 to 2 millimeters per day, and if you do an E2 level, you find them low, that is where the ideal place to add LH supplementation in those patients. LH supplementation will not work if you did not give adequate FSH stimulation. So in whatever literature you see, they always say with optimum dosage, an ongoing poor responder can be identified. And if these follicles do not progress, then adding LH makes sense. When you add LH to this group of patients, which are also can be labeled as Poseidon 1 and 2, if you have this many, then you get this many. Then we say that certain drug has acted. So in other words, in a hyperresponder, if you have adequate number of follicles like in the group 1 and group 2 of the Poseidon, if you add LH supplementation, then you get adequate number of follicles, adequate number of follicles. And this adequate number of follicles will in turn change the pregnancy rate. The explanation that was given for this suboptimal response by different people over the years was there is an LH beta variation which is not acting, or an FSH receptor abnormality, or there are different molecules of LH which they said association with polymorphism. But our work in the March 2018, which was published in the European Journal of Obstetrics and Gynecology, which is the first paper on the role of pharmacogenomics in deciding LH supplementation, is giving an explanation why there are hyperresponders, which I will explain in a minute. In this paper, what we did was we studied who needed LH supplementation, and with the use of gene sequencing and looking at different variations and doing a post-result analysis, we came to the conclusion after studying 200 variations in the FSH and LH receptor, the LH gene at 312 position has 3 polymorphisms, A by A, A by G, and A by G, which I'll explain in a minute. In this, we have taken the sample of blood, extracted the DNA, did the genotype, and then did the data analysis. This is how a Sanger sequencer looks like. And this is called an electrophoreogram. Sorry for my pronunciation. This is how a report that comes from a Sanger sequence, which tells us where exactly a particular letter is missing. These are useful to analyze the information. And in this study, what we found was women with homozygous or heterozygous required LH supplementation, whereas women with a normal type did not need LH supplementation, which I'll explain in a minute. This is a 312 A by A position in which this is the circulation, this is the theca cell, and the LH is freely going into the cell. So the action of granular cell is very easy, and these patients have higher testosterone, higher irregular cycles, more AMH, and very few times they need LH supplementation. When you look at the G by G pattern at 312 position, the molecule, the amino acid arginine is replaced with serine, and in this, the LH has difficulty into passing into the theca into the granular cell. So supplementing LH makes a difference. And these patients, when you look at them, most of the time they have regular cycles, borderline AMH, a testosterone which is most of the time low or normal levels. And sometimes when you look at the day 2 FSH levels, their FSH is higher than the LH. That means if the FSH is 5, their LH can be 3 or 4, which till now we thought it is normal. But when you look at reversal of this pattern, these people will have higher cancellation rate, and at LH supplementation, you get optimal responses. This is the in-between category. The Poseidon group, which we are trying to work with Dr. Sweta Mittal and also with Devaki Gunashila and the other LH groups, where we are trying to link the Poseidon group LH supplementation to this G by G pattern, which in a year's time, we might be the first group in the world to provide answers to the relation between the Poseidon concept of LH supplementation to these receptors. This is a schematic diagram showing an LH-CGR 312 does not need LH supplementation. An LH-CGR at 312 position needs 37 NH. And in the suboptimal of the poor responders, LH-312, you might need 75 units. But one most important thing all of us remember is the role of LH supplementation comes in only when you give adequate amount of FSH stimulation, which should be based on the age, the BMI, either the antral follicle count or the AMH and the ovarian surgeries, and then decide on a common dosage. Only after give adequate dose of FSH, then if the response is not proper, instead of increasing the FSH, add LH, which will most of the time fall into these groups. This concept is called pharmacogenomics. We were lucky to have a publication which was published in March being discussed in Brazil, which is in the Brazilian language, which was they are trying to integrate this receptor work into Carlo Alvighi's work of Poseidon concept. And I'm proud to share this information, and I'm proud to be an Indian to contribute to the area of science to the global thing. The carry home message of this group is the Poseidon 1 and 2 should be identified before we start the group. If you, in spite of giving adequate dose of stimulation on day 5 or day 6, if the follicles are not growing, instead of increasing FSH, add LH, and in future, you will have a lot of receptor work available at a much, much cheaper cost, which will help you to decide who needs receptor LH supplementation based on the receptors. So the key message of this topic is LH activity addition is important provided you give adequate dosage. Giving importance to antral follicle count and or AMH when you're starting the dosage. Identifying the patients whether they are hyper responders or poor responders or normal responders in this existing cycle, or analyzing the previous information to identify them and prevent the poor responders will go a long role. One important thing is just telling the patient go for oocyte donation is very easy. But one thing remember, we are not genetic providers, we are medical solution providers. That's what I wanted to emphasize. I thank you, and I will now pass on the screen to Pavitra and then Dr. Shweta Mittal for our case presentations.
So thank you, sir, for this elaborate presentation and taking us through the Indian research on LH receptor polymorphism, which is also first of its kind, and possibly this will help clinicians in managing their patients better. So with that, I would now like to hand over the session to Dr. Shweta Mittal, who will be taking us through important case studies in the management of low prognosis patients. So over to you, Dr. Mittal.
Thank you, Dr. Pavitra, and thank you, Dr. Ramaraju. It was really a very, very elaborate and extensive presentation. So just moving forth, I have brought in 3 case histories, and I'll present the first one and then possibly we'll discuss it. So this patient of mine, she's a 28-year-old lady, a case of primary infertility for last 4 years. She underwent IVF at our center for an unexplained infertility. So if you look at her ovarian reserve, her AMH was very nice. It was 4.2 nanograms, a bit on the higher side, though her antral follicle counts were about 7 to 8 in each ovary. She was not a PCOS, but a patient with a very good ovarian reserve. She had, of course, gone through a couple of IUI cycles in the past, which had failed, and that is the reason she entered an IVF cycle. So since most of the cycles, I think almost 100% of the cycles are an antagonist cycle in our center, so she was started. So the normal protocol is that we do a baseline scan, we do an E2 level, an LH level, and a progesterone level. And since her AMH level and ovarian reserve was very good, it was decided to start her with 150 unit of recombinant FSH. So this is the chart. If we look at the first day of stimulation, where she had an antral follicle of 7 and 8, a baseline endometrium of 4, and a baseline estradiol level which was less than 50 with an LH of 5.28. So she was given a dose of 150 recombinant FSH, 150 unit for 5 days. Now, at the end of 5 days, when she came back on the 6th day, the follicles were emerging. However, none of the follicles had crossed 12 or 13, and endometrium had gone up to 7 millimeter. E2 rise, we were expecting a little more, but it was 212. And LH, what we just heard from Dr. Ramaraju, that yes, there would be some subset of patients who would start showing a reduced or a suppressed LH even before we start an antagonist, and our LH was 1.47. So that is the time we decided that, okay, let's add some amount of recombinant LH to this patient. And the dose of the FSH was kept constant because she was a normal responder otherwise, and an LH molecule was added. And then we called her after 3 days, and we saw that the follicles still were about 15, 14, 13, and they were emerging. And at this time, the estradiol level had risen to some more extent, which was close to 500. Now, the LH level, of course, because still the antagonist was not introduced and it had further gone down to 0.49. So we continued FSH and recombinant LH, but because the follicles had already become 15, so we now added a small dose of antagonist. And on day 11, we see, continuing the same dose, that all the dominant follicles were achieved more than 3 in both the ovaries with a good endometrium and an E2 level of 1245 with an LH of 1.09. And that is the time where HCG trigger was administered. And we normally schedule OCR somewhere between 35.5 to 36 hours post HCG. So we got 11 oocytes, 9 were matured, out of which 7 fertilized. We transferred 2 day 3 embryos in the fresh cycle, which was negative. Fortunately, she had 1 good day 5 embryo, which was cryopreserved, and it was transferred in the next cycle, and she came positive. So I think we can start with Dr. Ramaraju, that by analyzing this case in your clinical setup, what are the possible things, what you do if you come across such a patient who's showing where we are expecting a good response, but at the end of 5 days, maybe the E2 level is low, a little lower recruitment, and those patients who show a sudden suppression of LH.
First of all, is if that patient comes to me, I would say that's an excellent management. And sometimes if I get a same patient who comes to me with that data, my answer is the excellent management. The reason to say excellent management is as follows. One is we got optimum number of oocytes. Second thing is, when you look at the doubling time of the E2 levels, the doubling time of the E2 levels is quite satisfactory. The beginning E2 level, the day 4, day 6, and the day 11 E2 levels are not erratic. The LH supplementation is the right decision because with adequate dosage, the follicles were there, but the follicles were not growing. And then you have added LH at the right time and produced optimal stimulation. And the most important thing was you have given time for the follicles to respond to the FSH and the LH, and that has given to produce good quality oocytes. Most of the time when we add LH and after 3 days we see, then we again become restless and fiddle with the cycle by adding or tinkering with the FSH or LH, which was not needed. And I would congratulate you for the excellent management of this patient.
Dr. Devika, so normally what happens is when we see a low response, there is a tendency, even in expected hyperresponders, to suddenly increase the dose of FSH. And that is the time when we suddenly see a lot of follicles maybe cropping up. So I want your view about this case management or anything else you want to add on.
No, I think I would have done pretty much the same thing. As you can see, as you have shown in your chart, by day 6, she really didn't have anything coming up. And yeah, so you can see that the emerging follicles were 6, but none of them were more than 1 or 1.1 centimeter. And that's the time when you actually added the LH and you held on with the antag. You can either do a fixed antag or you can do a variable, and we do a lot of variable antags in our hospital. And I think you just held on until it came down. Although the LH was dropping, you held on till day 9. And then when you start to get a 1.5 follicle, then that was when you must have thought that, okay, fine, it may just go out of hand and she may just have a sudden surge or whatever. And you put in an antagonist. I think it was, like Dr. Ramaraju said, very well managed. And you got a good cohort with a sensible E2. So no, if you had maybe increased the FSH as a panic reaction on day 6, then I think your E2 would have shot to the roof.
So I also wanted to put one point that I've seen, especially even in my donor cycles, that if there is a sudden suppression of spontaneous LH, they do show a little stunted growth, or they take a longer time in their stimulation vis-a-vis where we were expecting these donors also to do very well. So what is your opinion or your observation in such cases?
I don't know if you should actually, worry so much, unless LH is rising. I don't know if you should worry so much about the LH. I mean, I would go more by the follicular count, and like you have done, there was no follicles coming. So that was the time that you had to, add on LH. And yes, these are all the vagaries of stimulation. LH does come down, but and you added the LH at the right time. So that's all I can say. I mean, I've not actually looked very closely at donor cycles with regards to the falling LH. But with this patient, one thing that you did mention was that you had she had previous failed IVF cycles. Is that correct?
No, she only had previous failed IUI cycles, and this was the first IVF cycle.
Yeah, that's okay. I mean, I think it has been managed very well. I mean, I have not really found a correlation which I have really noticed with a falling LH and a stalled response.
So Dr. Ramaraju and Dr. Devika, I think we all unanimously agree that if we have an expected good responder and they suddenly show a little less response, we would not really jump on the doses of FSH, and we would identify those subset of patients who might be benefited with LH, and prolonging the stimulation will not really make any difference, and a flexible antagonist protocol will be a better option for them. And then we can decide, depending on the terminal estradiol level, whether we want to give them an HCG trigger or an agonist trigger. Yes, Dr. Devika.
Can I just interrupt? Just with maybe I'm diverging a little bit, but then when you do follow I would like both of you to answer this. When you do follow the day 6, fixed protocol, would you think that would affect the result at all? If you had started the anti on day 6?
So in a lot of occasions, I've seen even the LH rising, I mean, even going up to 15, 16, and introducing antagonists that time, haven't really seen any difference in the oocyte quality. At least the embryologist really hasn't told. And in PCO patients, especially who show a very late response and then they start booming, I think an antagonist protocol, or in a poor responder. In poor responder, anyway, possibly we are dealing with even the age-related oocyte issue and not really the stimulation-related directly. Dr. Ramaraju, do you want to put any view on that, on oocyte quality in a flexible antagonist protocol?
One thing is, as long as the rate of rise of follicle is good and my endometrium is good and I have good cervical secretions and my doubling time of E2 levels are fine, I wouldn't bother about anything else.
Okay. So should we move on to the next case?
Yes.
Okay, thank you very much. And we'll move on to the next case. So this patient, she's a 35-year-old lady, again a case of primary infertility, was undergoing second IVF for male factor. I will just briefly tell you what happened in the first IVF. Her AMH was 1.4 nanograms per ml. AFC was decent, right ovary 5, left ovary 4. In the first IVF, we gave her a recombinant FSH 225 unit and the dose was not changed. And it was roughly administered for 10 days. And then the HCG was given and we got 5 oocytes. Out of 5 oocytes, M2 oocytes the mature oocytes were only 3, out of which 2 fertilized. However, the embryologist said that there are no good quality embryos to be transferred at all. And so the patient was counseled. Now, this was the patient where embryo transfer did not take place, and then she came for a second cycle. So our problem was that she's 35, AMH was okay, it was falling in the normal range with a normal AFC, but with the standard dose of gonadotropin, she did show a little lower ovarian response. And then after counseling her, and then we made a strategy for her in the second cycle. So normally either we give a luteal phase estrogen to them to make a better cohort, and or we give a cycle of OC pill, either of the two. Now, when this patient came on day 2, her antral follicle count was 4 on one side, 3 on the other side, with a 4 millimeter endometrium, E2 way below 50, LH baseline 3.26. So now, keeping the previous response in mind, this is the policy in my center that we start with a recombinant FSH with a recombinant LH composition. Since in India we don't have a 2:1 combination, we still stick to 75. And we just heard Dr. Ramaraju saying that patients who really need LH could be vacillating between 37.5 or 75. So giving it for 5 days, when we called her on 6th day, again we saw emerging follicles, but none of them had really crossed 14. Her E2 level rise was 412 with an LH which was still 3.47. So we continued, I'm sorry, this is 300 unit of recombinant FSH with LH. We continued it on day 9 when we called her back. Now the follicles were in the range of 14, 15, and 16. E2 levels somewhat remained the same. It was not rising. And suddenly we saw that the LH level had fallen down, which was 0.49. But because the follicle was 15 and 16, so we continued the same proportion of FSH and LH and introduced an antagonist. She took a little longer time. On day 11, we could see all the dominant follicles emerging, and the terminal E2 had gone up to 1256 and LH was 1.58. That is the time HCG trigger was given. Now this time, we could get 8 oocytes luckily, out of which M2 oocytes were 6, 5 had fertilized, and she made 2 day 3 embryos which were transferred, and she came positive. So now my question was, I think I'll start from Dr. Devika, that this is a patient where in the first cycle you expect a better response, and then you get just a suboptimum oocytes, they fail or they don't make an embryo or the embryo transfer fails. So in the second cycle, what is the strategies what you adopt to optimize a cycle?
Yeah, I think you've done very well. I'm a strong proponent of this LH, and I quite like the drug, and I use it a lot of the time. And what I would have done different, I think, looking at the previous cycle, I would have started off LH right from the day 3 that you actually started. So I would have given her, shall we say, FSH and LH in the ratio of 2:1. And although we don't have that fixed Pergoveris, that drug in our country, I think I would have added on a little bit of LH right from the beginning. That is something that I would have done, because I do it, and I do find that I use it a lot in poor responders, and I find that we do get a good result with it. I mean, that is the only thing that I've done different in this patient.
So Dr. Ramaraju, since in this case, yes, we did start with a recombinant LH from the beginning of the cycle itself. My point was that since there is a concern in all the practitioners that they have a little hitch in using a recombinant LH also, keeping in mind the cost, what do you think? Are you happy with introducing only 75 units, or would you use 150? So 300 is to 150, because we use 75, either we give 225 units or 300 units of FSH.
Can we go back to the previous slide where you're showing the data of the patient?
Yeah.
Here, there are 2 things I have to answer. One is the comment on the cycle. The second is the dose of the LH supplementation. One question I have is, do you take BMI into consideration when you're planning your dosage for your patients?
Yes, very much. Yeah.
Yes.
So I kind of have a tendency to increase the dose by about 50 units if the BMI is more than 25.
And second thing is, do you alter your dosage depending on the amount of AFC or AMH?
Yes, I do. I definitely do, because Okay, in this case, normally our standard dose, if the AMH is good and the age is in the right range, we would give 225 units, which we did in the previous cycle. And if it's only if there's a poor response or suboptimum, that we go to 300. And in very good responders, I would keep to 150 or maybe even as low as 125.
Here I have one more question. What is the total number of antral follicle count in these patients?
So here it was about 7, 4 and 3.
4 and 3. Yeah. And the other thing is with the age of the 35. And one thing I was puzzled with this information is on the day 6, your E2 levels reached 412. That means they underwent 3 doubling times.
Yes. But however, the follicle, so I also want to know that how much importance would you only give to your E2 level rise, or would you be correlating the follicular recruitment with the E2 level? Because sometimes I feel that we have very, very ultra sensitive machines too. And just depending on exclusive E2 levels or only depending on AFC sometimes can be misleading, or the emerging follicles. So what is your opinion, Dr. Ramaraju, on that?
If I have an E2 level of 412 picograms, then I should see cervical secretions there.
Mm-hmm.
And if I don't see a cervical secretions, then I question my value of 412.
Okay, so
I wouldn't go too much by E2 levels. That is my opinion and my experience. I would kind of try to correlate both, and I would go more by the follicles, I think, if they're not correlating very much.
So Dr. Ramaraju, in this case, would you have started with 300 units and a combination of FSH with LH, or would you have done something different?
No, I wouldn't do anything different. My only concern was, is my lab reporting the values correctly?
Yeah, so yes, so definitely my lab, of course, runs a control every day and has a very, very close observation and has a biochemist all the time sitting on the head. And we do that. We always do that every time there is an altered report and it is rerun again. So it's a very valid point taken that, yes, it's very important. I think this is a message to everyone that we cannot depend exclusively only on E2 levels, or we have to have a good correlation, and possibly doing an ultrasound yourself would help quite a lot in knowing that how many follicles are emerging.
I would like to add one more point there. If that lab which we are getting the sample is an enable accredited,
yes,
for the estrogen estimation, then we can ask for the uncertainty value of the lab for estrogen.
Yes, that's right.
Because that will give us the to what extent we can what's the range we can expect.
So in this case, sir, you would have again gone on a flexible protocol for antagonist?
From the protocol wise, the things are fine. My only concern was when I was looking at the values.
Yeah.
And regarding your second question about the 37 or the 75 or the 150, in one of the drug regulations that were submitted by the low risk group in the initial group, they also submitted data effective dosage from 25 units, 50 units, 75 units, and 150 units. They found different responses. So based on the receptor work, we give 37 units. But if I have to give it blindly, depending on the ongoing poor responder, I would stick to only 75 and nothing else.
Okay, I also just out of the box one question to both of you. Do you think that this particular case you would have done some androgen priming before starting a second cycle in patients whom you think have still decent reserve or maybe borderline low reserve? And what are your views on androgen priming?
The answer is no for me, because what happens is the whole stimulation with 300 units went off smoothly when you remove the E2 levels. The follicles you got 8, of which we had a good fertilization rate, which also shows that your cohort of follicles which you obtained were good. And then you had good quality embryos and a pregnancy. That shows, even though the number were not perfect, the process is perfect, so that's the reason it gave the pregnancy.
Yes.
I have no experience with androgel. I mean, androgen, either the gel or the patches or whatever it is. And I don't normally use it, so I
And what
wouldn't be
about
able to.
experience in aromatase inhibitor along with starting the ovarian stimulation? In this case, patients, not in cancer patients. I'm talking about in poor responders. It's just a
Yeah,
question, but different from.
we do. Sorry.
ahead.
Go ahead, sir.
Go ahead.
We're talking about poor responders. We do a lot of that dual stimulation, which is the Shanghai Protocol, or what that's what it's called. It can all be called as dual stim. And we do use letrozole there. And along, if you look at the protocol, it's a clomiphene citrate throughout the cycle with the letrozole. So we do use that sometimes if patients are willing to come in for embryo pooling. That's when we use.
And what about you, Dr. Ramaraju? Have you started the dual stim? Do you believe in it? Or
Yeah, the answer is yes, but I'm not doing it at the moment because I'll answer the first thing is the androgens, we don't use it. We use DHA as a supplement when the AMH is low, around 0.6 to 0.9, where we also estimate the testosterone levels. And if they're very low, then we use 2 months of DHA and reassess the androgen follicle count. And if we are satisfactory, then we take up for the cycle.
I have one question that if we look at the Poseidon group, say 3 and 4, this is what you're talking about, who have very, very low AMH, by androgen priming, will they really gain a benefit? Or I mean, there is a lot of now work on duostim. I really don't know whether the duostim or 2 stimulations in 2 different menstrual cycles would effectively have the same results. We are just very recently started recruiting patients for duostim, so possibly we'll come with some answer.
Like in the Poseidon group 3 and 4, is one thing is in the given number, if you are able to stimulate that number efficiently, there is some better chance of pregnancy in the Poseidon group 3.
Because age-wise, they are still in the lower age group. Yes, definitely.
Yeah, but whereas in the upper age group of the Poseidon group 4, I'm not very sure. But in the Poseidon group 3, my answer is I'm convinced about the concept of preparation of the patient before you start the cycle.
Yeah.
Yeah, Dr. Shweta, the thing is that with the duostim, we've done a few cycles because we've had patients with poor reserves, and I do not know whether it's only here, it's in the south, or whether it's in the north. I'm sure it is all over India that we are seeing younger patients with a poor ovarian reserve, maybe from the last 10 years, and it's just becoming more and more common. And we have had 2 pregnancies with our duostim protocol, but we've not done that many. And we're looking forward to seeing what happens with your duostim trial.
Last, I think 3-4 months, we've started doing duostim. And I think in next 6 months, we'll be able to get more insight into it. So I think what the take home was that if you're looking at Poseidon group 1 and 2, by adding LH in the middle of the stimulation or from the beginning of the stimulation, we can rescue the cycles. If you're looking at Poseidon 3 and 4, they possibly will not have any beneficial effect during the stimulation. But in Poseidon group 3, a priming or a pre-cycle modification will help. However, in the Poseidon group 4, I think it is just the clubbing of embryos or maybe nothing which will help. So do we agree on this, Dr. Ramaraju and Dr. Devika? So I can go on to the third case then.
The answer is yes.
Yeah.
Okay. Thank you. So I think we have no debates on that, and we'll move on to the third case. It's a little different case. Well, nothing new about it. She's a 32-year-old lady, but interesting part is she's a case of secondary infertility, a known case of hypogonadotropic hypogonadism, but that is not the reason for which she's going through IVF, because both the husband and wife were thalassaemic carrier and unfortunately have had a thalassaemic major child. And now this lady, not only it's not IVF that she's going through the cycle, but she wants a PGD, and she also wanted an HLA typing. She's a typical hypogonadotropic woman with an FSH of 0.83, LH 0.2, 3.2, AMH was 3.91 nanogram. We know that in hypogonadotropic women, we will have all the combinations of AMH, and we should not depend our decisions only on AMH. They could have a PCO-like pattern, they could have a normal responder-like pattern, and many hypogonadotropic women will also have very low AMH, and we should not give much importance to it. Now, in the first IVF cycle, we started, which is the standard protocol of urinary HMG, and it was started at a dose of 300 units. The reason was because for PGD, we need to club more embryos, and we need more embryos for biopsy. But unfortunately, in this lady, what happened after 18 days of gonadotropin, the E2 levels were still 329 picograms. They're little acceptable, but we wanted more follicular recruitment. We could see that, yes, she's behaving like a typical hypogonadotropic woman. So we decided to shift her to a recombinant FSH and LH preparation, which is 300:75. So in the next couple of days, so that was total 22 days of gonadotropin. Her terminal E2 again was 1293. We got 10 oocytes and 2 blastocysts were frozen. But since 2 blastocysts are not enough, to bring a PGD biopsy, so we decided for a second stimulation. So in the second stimulation, the only difference what we did was that we thought of giving a recombinant FSH and an LH combination. This time, she basically took 13 days for stimulation, which the combination was 225 unit and 75. We got 13 oocytes. The terminal E2 went up to 1345 picograms. And this time, 3 blastocysts were frozen. So we have basically 5 embryos. We have just done a biopsy recently, and we are now awaiting the result and the embryo transfer. So the reason why I brought in this patient, that normally hypogonadotropic women, they do very well with urinary HMG products, but sometimes we do come across certain women who respond better when we give a recombinant FSH and LH. So I think starting with Dr. Ramaraju, I'm sure he will have some points and his views. I want your views, sir, first.
I'm skeptical, biased about HMG. The reason is the unit measurement of HMG is entirely different. It's based on the ovary weight that produces in the mice. So the batch to batch variability of the product can be an issue. Why can't it be a suboptimal product which had a batch to batch variability and did not respond properly and took a lot of time?
Yes, I think I completely agree. And this is what we absolutely thought, that it is basically not the molecule, but it was possibly the batch of the product. And that is the reason. And the patients who are hypogonadotropic, they are so frustrated taking injections for so long. So changing over actually was a better decision in her case. And in the second cycle, we could see that she only took 13 days vis-a-vis 22 days in the first cycle. Dr. Devika, I want your opinion that how do you deal with such patients, or is there anything else you want to add?
Nothing really. I might have started with a 150/75 dose of FSH and gone on for maybe a few more days. Yeah. But and then titrated it to maybe increasing the FSH or increasing the LH depending upon how the stimulation went on. But it's quite good, and you got 3 blastocysts and you picked up 13 oocytes. So nothing more to add to this. I think she's okay.
I have one more question. Like when we look at 23 oocytes,
13, sir.
13 and the first cycle, 10.
Okay. Yeah.
We got 5 blastocysts.
So, this is an observation, what we see, that especially in our population, those patients who are carriers of thalassemia, and also we see it in balanced translocations, that the conversion rate to blastocyst is much lower than we expect in other patients, even though they don't have infertility. So we would have been more happy if we would have had about 8 or 9 blastocysts. I don't think this patient wanted, I think she wants an HLA typing. For HLA typing, this number of embryo, of course, is not that enough.
That's my only question. Otherwise, the protocol, I'm perfectly fine.
So she's still awaiting. She's also exploring bone marrow, now transplantation. So I think this ladder is difficult for such patients, and it is difficult to stimulate these women and get the optimum number of embryos. So if we have, do we have 5 more minutes? I don't have a case history, but maybe we can put in the fourth case, which is a genuine, a lady who's say about 40 or 39 with low AMH. And what are your views on starting on, since this presentation or the whole webinar is on LH, starting on LH from day 2 or day 3 of stimulation? So what do you do? And Dr. Devika, your views.
How low is her AMH, you said?
Suppose it's about 0.4 nanograms per ml, and we get a patient who's about 39, which is a very common scenario. So, and you want to stimulate her, would you be starting with the LH moiety in whatever form you want to use from the beginning of the stimulation, in the middle, or you would base your findings on the baseline LH levels, or irrespective of LH levels?
So Dr. Ramaraju, do you want to go first, or?
Yes.
I would like to go first.
Okay.
Listeners, at 39 with an AMH of 0.4, and I would like to look at the antral follicle count. If they are 2 or 3,
Yes.
then I would tell the patient that I have very few pregnancies with the data. If you want to continue, I'll go ahead.
Can I say something? I agree with Dr. Ramaraju. If there are no follicles there, you're not going to fish them out from anywhere.
Yes.
Whatever is going to come out is what is there. And if it's not there, it's not there.
So by even increasing, the dose of gonadotropin to a very high level actually will not solve anything.
No, it won't.
Minor stimulation would possibly bring the same number of oocytes. And there's another one very important thing which I wanted to ask, that there is a tendency of many IVF specialists in an antagonist cycle that after day 5, irrespective of the LH levels or the follicular recruitment or the E2 levels, they have a tendency to change the molecule and add an LH to the stimulation. So what are your views? Because we do not do that at all unless we see a stunted growth or a very highly suppressed LH levels.
In a patient who is an ongoing poor responder, there's a role for LH supplementation.
Yes. No, I'm talking about a normal responder woman who's doing very well, has a good E2 level, but just because it's an antagonist cycle, people like to change over the moment the day they add antagonists, they like to add an LH. And I want to know your views before we can, end these cases.
The literature has no evidence on that at all. In a patient who is responding well and going well, when you're adding antagon and doing an LH supplementation, just because other people are doing it, there's no rationale. But when it comes to receptor, my answer might be yes. But if I don't have a receptor information and I look at an ongoing patient who is responding perfectly, the rate of follicular growth is fine, and I start antagon, I would not add LH supplementation there.
Yeah, I agree with Dr. Ramaraju. I would not add an antagon. I would not add an LH just because I've added an antagon. Also, I would not increase the dose of FSH because I've added an antagon. The second thing also is that if you have a uniform cohort, let it be. It'll just grow by itself. I mean, with just the same dose of FSH, will just do quite nicely.
So I think we all unanimously agree on this, that a normal routine addition of LH is not required. LH would be only required in the few subset of patients which we just discussed. And possibly that is how we can optimize and individualize the stimulation.
I would like to add a few more points.
Yeah.
The concept of LH is changing. In few years, with the advent of genomics, I feel in the subgroup in normal responders, to avoid possible hyperstimulation, we might be using LH. That's the future. In 2 years, you'll have that information.
So in earlier days, when we used to use a lot of agonist cycles, and in coasting period, we used to change over to LH molecule to act as a coasting agent. We have done that, but with antagonist cycles and agonist triggers, now we are very comfortable.
We'll have to send all our samples to you, sir, for the LH polymorphism.
Yes, we've already started collecting the samples, and very soon you'll be receiving. And it has been a pleasure, having a lot of discussion with both of you. And I think I'll hand over back to Dr. Pavitra. And if there are any questions from all our delegate members who are attending, we are happy to answer.
So I thank Dr. Ramaraju, Dr. Mithil, Dr. Gunashila for being here on this webinar and giving a comprehensive review on the use of LH, particularly in the low prognosis patients. And we have about 400 delegates who are logged online. I will share my screen, and there are lots of questions that have already come in. So I will do that right now. So start sharing my screen. This will stop others. Yes.
Pavitra must be happy with the
So can you see my screen?
Yes.
Yeah, so this is the live question answers that are going on. So I'll just, there are lots of questions that have already come from.
I mean, I don't have issues in taking the questions, but I will ask the other panelists also, or we can take at 10 questions or 15, depending on what my
Yes, yes. There are lots of questions, but we'll just take a few questions because some repetitions I can see are there. So I will just take which are already covered in the topic or the talk. So first question I'll take is from Dr. Gunjan from Amritsar. So she's mentioning still a question remains, add LH on day 1 or 2 or at 14 millimeters of size. So Dr. Gunishila would like to answer that.
Yeah, I mean, if you're talking about a poor responder, I would add it on day 2 or day 3 when I start the stimulation. If you're talking about a Poseidon, shall we say 3 group, and I might add it, or if she's had a situation where she's had, you know, a good stimulation but had poor response, and in the previous cycles, I definitely would add it from day 2 or day 3, in the ratio of 2:1. That is what I follow. And at 14 millimeter, like what Dr. Shweta Mittal said, that you know, if the follicles are not coming up and on day 6, and you know there's no follicle that has crossed the 1.1 or 1.2 centimeter size, then yes, I would add a little bit of LH, recombinant LH.
Okay. Any other views, Dr. Mittal, Dr. Ramaraju, on this?
We have to just be very clear that there would be two scenarios. One scenario is patient who's either shown a poor response in the previous cycle, or in whom we have already labeled that they could be poor responder, where we would be starting the LH moiety from the beginning of the stimulation. And the second subset of patient would be where they had absolutely normal LH levels, normal AFC, normal AMH. We started with recombinant FSH in the dose which we thought was the best for her, and suddenly she shows a low E2 rise or a stunted growth, and that is the time where we will have to add in the middle of the cycle. And one is patients who are like on prolonged downregulation or who have over-suppressed LH levels, again, where we will start from the beginning of the cycle.
Okay. So there was a question from Dr. Diego, who also logged in, but I think so this was on one of the cases. I'll just read out the question: is why the first started treatment was done with less bioactive FSH, increasing as proven in the second trimester the number of days of treatment. This was actually one of the cases. So we'll just
case had a very good AMH level, which was 4 nanograms. She was a very young girl. So we decided on 150 units, depending on her AFC and AMH. But in the second one, we started with 225 unit in the first cycle and 300 unit in the second cycle.
Yes.
And the third case was a hypogonadotropic hypogonadic women, where generally a urinary, HMG is used. So this is what I wanted to bring forth, that yes, it may not work in all the patients.
Okay, so there are some other questions which talk about the use of LH measurements. How accurate are they? Dr. Ramaraju would like to answer this question. How accurate are the LH measurements in the current practice? Should we rely on them?
There are two things. One is LH has a biphasic, has a pulsatile pattern. The second thing is the quality of the lab you're taking in. So a single LH measurement, when you're making a critical decision in the mid-cycle, if the value is higher, I would prefer to repeat it to confirm that I'm not looking at an amplitude of higher pulse rather than a lower pulse. The number of times I do an LH in my cycle is only few times at the beginning of the cycle and seldom anywhere between the cycle. So I'm not too much relying on the LH supplementation, because whenever there is an ongoing poor responder or a suboptimal response, I add LH supplementation. So my practice involves less LH, less monitoring of LH during the cycle.
Can
Yeah.
I put my one
Yes,
point?
yes, Dr. Mittal, please. Yeah.
You know, we took out our data. It's gone the other way around. I would talk about hypersecretors of LH, and we took out our data and we realized that no matter what the day 2 LH was in hypersecretors, even it was as high as 24, 26, and even on day 6 of stimulation, an LH rise actually was not detrimental to oocyte qualities. I'm talking about hypersecretors. We do make use of LH. I mean, we do estimate, but that is only to identify patients who have very, very low levels of LH and who will possibly be benefited with LH supplementation.
So with that comment, Dr. Mittal, there was a question which was asked earlier as to what is there a use of LH in hyper responders? I think this was a question which was asked.
Yes, I think possibly there is, again, we presented data of all 15 women who are absolutely PCO, and they take a very, I think they could be having an LH receptor polymorphism, that subgroup. And I think Dr. Pavitra, when we recently met, you said very recently one article just has come up where they respond to an LH moiety, which has to be added to FSH, and then only they show response. But they are the women who have very, very high levels of AMH and who are somewhere hyperandrogenic, but they respond to this molecule. We keep giving FSH and increasing doses for days together, and the moment an LH moiety is added, they start showing better response.
I think that question to that answer will be in Dr. Ramraju's once he brings out, makes his thing more commercial, because he's talking about AA, AG, and GG. And so I think according to you, sir, AA is the one who actually hyper responsive. You may not need to use that much of medication. Is that correct?
Yes. So I think they could be having.
I think we'll give it to Mark to distribute it free of cost along with the LH product.
Good idea.
So that it benefits the patient.
And the other LH use is, of course, as a coasting, where you completely withdraw the FSH, but more so in agonist cycles.
Okay. I think that answers the question. I'll not take the questions on androgens because it seems that experts are not using it in the current practice. But there has been a question on DHA. DHA.
So I have used both the molecules, DHEA as well as the transdermal androgen gels. And there is a very recent talk which I heard, and he said that possibly a transdermal androgen is a direct androgen and will work better in priming the follicles as compared to DHEA because it needs to be converted to testosterone so as to get converted to estrogen. But yes, of course, we cannot do a rampant usage. It will be maybe for a very, very selected subgroup of patients.
Pavitra, if I may answer, I don't have any, unfortunately, I don't really believe in DHEA. It has not worked in my hands. I think it's more a tool where, for me, I think it's more a tool where you can buy time. You have a lot of these young women who come in who are quite devastated with the fact that their AFC is not good or their AMH is not good, and somehow, for it to sink in, you actually give them DHA and say, okay, because they're continuously saying, can't you do anything, and then you give them the DHA. But frankly speaking, it has never worked in my hands. And we're about to embark on a trial on this androgen gel, and hopefully we'll be able to get some experience from that in our hospital. But with DHA, I'm not a proponent of it.
I have to add one thing. Of late, I'm seeing a lot of women being used vitamin A retinol or retinoids, and they are decreasing the antral follicle count drastically. Are the people aware of it? The first question.
No, I am not. Vitamin A is for the pimples and all that, is it?
Yes, it decreases the antral follicle count.
Oh, I see.
Is there any data, Dr. Ramaraju, on that, or is it your observation?
No, not an observation. There's a data on that.
Very valuable.
And if you want to kill somebody indirectly, prescribe that preparation. And I'll provide the data because there are almost 2-3 human publications and a lot of animal experimentation where they found the density of the follicle decreases.
Okay.
And in 2 patients, that's where we tried DHA in them for 4 months. there was a marginal improvement, but I'm not sure that marginal improvement is because of the withdrawal of the drug or DHEA. But one warning I want to give to all our reproductive colleagues is the vitamin A, the retinoids are harmful for the ovary. The women are extremely happy when the pimples go off, the hair goes off, but they're not realizing the AMH is also going off.
So there's one, thank you for the comments. And there's one question from Dr. Vinutha. She's saying that she has put a case that she has one lady who's 32-year-old with an AMH of 3.3 and with a baseline FSH and LH, which is normal. And she started on Gonal-f 300 and Menopur 75, stepped up Gonal-f 300 and Menopur 150, yielding only 2 M2 oocytes, and then switched over to 450 Menopur. So what is, any comments on this?
Pavitra, can you repeat the question again?
So this is from Dr. Vinutha, who's from Dharwad. She's saying that one of her patients who's 32 years old has an AMH of 3.3 with a baseline FSH and LH that is normal. She started with Gonal-f and Menopur 75. This Gonal-f dose was 300 plus Menopur was 75, and then stepped up Gonal-f and Menopur, stepped up Menopur to 150 with 300 Gonal-f and yielded only 2 M2s.
How many?
And then switched over to 450 Menopur.
450 Menopur.
Yeah.
How many M2s? What? No,
Two.
2 M2s in the first
Only
cycle.
only two M2s. And later she has switched over to 450 Menopurs.
I think she needs to recheck her AMH, and I think she needs to do her antral follicle count herself. Are we missing on the diagnosis? Because there are a lot of estimation errors of AMH too, number one. Maybe we are dealing with some kind of we have come across patients who have very high AMH, and will very soon be presenting, but they also have very high baseline FSH. We have got the AMH repeated twice, and they are the patients who are like a resistant ovary, though the AMH is high, but they do behave like poor responders. And I think baseline FSH is very important in them, but her case, it was normal.
In that case, like I have an order, whenever you have a high AMH and a high FSH, some of them will have an alteration in the LH and the testosterone.
Yes.
So in the patient from which the doctor has asked, I have two questions. One is, when she's doing a follicular monitoring, she must have counted the antral follicles, and she must have counted the rate of progress of the follicular growth. Did follicular growth happen at all? That's my first question.
Okay.
If it has happened, then what is the rate of follicular growth? That will answer two things. There can be a drug issue, there can be a drug administration issue, and then the actual pathology issue. As a Pavitra, as a pharmacology person, what's your comments on that?
I think rechecking the diagnosis in her case is very important, and looking at all these parameters, and of course even also the BMI. Though she was giving a very high dose, and I do agree that drug issue or the cold chain break, something has to be seen in her city.
No, what I want to know from the doctor is, why did she, with an AMH of 3.3, why was her initial dose of Gonal-f 375 Menopur? Why did she think of even starting it at that dose? I mean, what was the reason to add on HMG or at that stage with an AMH of 3.3? I mean,
she has not given any explanation. She just asked a question. So that what should be done. So I think that's the comments.
Pavitra, there's a small suggestion of all the questions that have come in. You answer it with a reference so that they can download those information, so that whoever asked the questions will get the answers also. That's my request. I think the panel will endorse my request.
So in 2018 itself, in Fertility Sterility, a very nice review has come on the role of LH. Possibly that can be seen and read.
Yeah. That's a nice on all patient groups.
Yeah, on a very comprehensive way of the different indications where LH would be beneficial.
Yeah. So there are lots of questions which are repetitions. I'm not going through that.
Pavitra, my personal opinion is when you ask the panel, the people to ask questions, it's
Yes,
a
sir.
responsibility to answer it.
Yes, sir. So some of the questions you have already answered, sir.
Wait. It's our responsibility to put it on that site, the answers for those questions with the references, so that we are respecting their time in asking those questions. That's my personal opinion.
Okay, sir.
Can we take up Dr. Seema's question from New Delhi? How many days of antagonist is must before OCR, and do the days of stimulation? So general good responders can get ready in as low as 7 days of stimulation and maybe just 2 days of antagonist. And haven't seen any compromise in the oocyte quality, but any stimulation, I think lower than 7 days, it does affect the oocyte quality.
Yeah, we have also seen that the higher the doses of the medication and the longer the stimulation, the more SERs that are present in the oocyte, smooth endoplasmic reticulum. And when you have a lot of SERs in the oocyte, the quality of the oocyte is not very good. So that results in a decreased number of embryos. So
yeah,
I agree with both the panelists' opinion. Both the shorter duration and the longer duration have adverse impacts on the outcome. Shorter duration is less than 8 days, your quality is compromised. More than 16 days, again, your quality is compromised, irrespective of the number of oocytes you get. The only exception is hypo.
Yeah, I also think that the dosages are also very important in that oocyte quality, because if you give a really high dosage, it just spoils the oocyte to some extent. You get a lot more ACRs.
There is a question which has
from
been
Dr.
any experience in starting LH before the FSH? Well, I personally haven't done that. Either I have started along with it or in the mid-cycle.
And I don't have any experience on that also.
I don't act as a priming agent at all.
There is, I think, only one article by that Placido Domingo, who actually said that he started LH in just before the patient had a period for about 7 days, and then went on to start FSH. But I have not tried it, and I don't have any experience either.
Okay. So there's one more question from Chennai. It says, as there are few evidence that recombinant LH can be started prior to FSH stimulation, which enhances androgen synthesis, does it have any significance? Also, is there any impact on stopping recombinant LH 2 days prior to HCG triggering?
If Diego is online, ask his opinion.
So stopping LH before the HCG trigger definitely doesn't compromise the oocyte quality, because very little amount of LH basically is required for the oocyte maturity, and we are giving HCG molecule for trigger. And then I don't think any one of us have used it before the prior to stimulation as an androgen or a priming agent.
Okay, and any comments from Dr. Gunishila on this?
I'm not used LH before, actually the start of stimulation. So I don't have any experience in either, but I have read 1 or 2 articles. Like I said, that D. Placido, he has actually done some work on it, but I don't have any personal experience. So I don't think I'm competent enough to talk about this particular protocol.
Okay, so I think the next question is from Jalandhar. It says that LH is more than 15 on day 2. Why some doctors give antagonist on day 2 and 3? Then stopping gonadotropins from day 4. What's the role of the antagonist in controlling the LH? So the LH is more than...
We took out our data last year, and we found that these LH hypersecretors, there was no need to suppress the LH levels. Initially, we would also give it for 2-3 days, and then we realized that there is absolutely no compromise in the oocyte quality. So now, even if we see 15 or 20 LH as a baseline, we don't suppress it, and we just start the stimulation.
Okay, so so I'll take the last question. That will be to Dr. Ramaraju, and then subsequently everybody can comment on it. It's from Dr. Sandhya in Varanasi. She's saying that is there any standard protocol for LH used in each and every case? Will the results be better with the use of recombinant LH from the beginning of the stimulation along with recombinant FSH, or in mid-cycle? More or less, this question has been answered in the presentation, but if you all could attend to this query again, I could take it as the last question.
I've been working on the receptor for the past 4 years. And in the past 3 years, depending on the receptor, I've been starting the LH from day one. But the data that is available on the world, it's no way inferior when you identify an ongoing poor responder and start LH. It's only with time it will tell which is superior starting on day 2 or once you diagnose an ongoing poor responder. At this moment, the weight of evidence for both are equal or more in favor of starting it as and when you see an ongoing poor responder. But there is a difference. In the German group, where they started using a fixed dose of FSH and LH, they found there is a difference in pregnancy rate when they started fixed dose of FSH, LH compared to only FSH. So in a matter of a year or two, we will be getting better data for the Dr. Sanjay's question from Varanasi. But at this moment, starting it whenever you identify an ongoing poor responder is more than adequate.
Okay, so there's this question from, I cannot stop because Diego is putting questions from for Dr. Ramaraju specifically. And he's asking that, is it possible for you to explain exactly what is your SOP to define drug and dose, including the sequential use of every biomarker you use? So is it possible to exactly explain what is the SOP that is used by you to define the drug and the dose for that drug, including the sequential use of every biomarker?
Okay. I look at around 20 parameters when I start a cycle. And the first thing is I use only one single drug for each product. The second thing is I don't change the drug whenever I want. There should be a strong reason to change the brand, be it whatever product. When it comes to the dosage pattern, we use the following pattern. One is age of the patient, the antral follicle count, or the AMH, one of them. In the age, we divide them into 25 years, 30 years, 35 years, 37 years, and the 40 years. In the BMI, we divide them into BMI 20, 25, 30, 32, and 35. Beyond 35, we don't do it, but we try to discourage even beyond 32. The third area is we rely on more on antral follicle count rather than AMH. We also look into the antimicrosomal antibodies, which I find are more prevalent in southern India. And if those levels are very high, we add another 25 units. We also look into the number of surgeries that have happened in the ovary. If the woman has an endometriotic surgery, then my dosage schedule is different. The woman has a drilling, multiple drillings, and the volume has come down to a normal ovary, my dosage is higher. So that's the pattern I look for my FSH dosage. The second thing is when I add LH, I base my LH on the GnRH receptor, that is the G by G, I add 75 units. If it is A by G, I add 37 units. If it's A by A, I don't add any LH. Then the third information I look at is when you do an ultrasound, I look at the vascularity when I put on a color Doppler and an ovary. Sometimes even though the ovary looks big, the vascularity looks very scanty in blood flows. There I might adjust the dosage at the beginning of the cycle. And one more thing I add to my stimulation protocols, which helped me personally, is to write how many oocytes I'm going to get in a given patient and then correlate them to the stimulation protocol I do. A lot of times my ego gets hurt because it mismatches, but with time, you try to develop and understand your drug better. You write 10x and you get 15, that means you messed it up or your assessment is not perfect. There comes a time when you'll be able to come within 20% of that range And that is the ideal optimal stimulation. For example, you're calling 10 people for dinner and cook for 5 people. The host is the problem, not the patient or the guest. That's my personal opinion. Yeah, that means we should understand our stimulation protocols better. Another one thing that is lot of sadness I can say is, in the last 30 years, the developments have happened in the drug, in the downregulation, in the luteal phase, in the monitoring of the lab, but nothing has changed in the last 20 years in the follicular stimulation except measuring E2 levels and follicular growth. Unless there is a concentrated research effort that goes into monitoring the follicular development and improving what information we have, then only our stimulation protocols will improve. Recently, we tied up with Samsung for the past 3 years, where we are trying to link follicles that are growing, all the follicles from day 1 to day 10 are being linked up into like a BPD, serial BPD measurements. And we are finding surprising information. If you change the dosage, the rate of follicular growth changes in a different way. So the emphasis should be finding the optimal dosage, sticking to the dosage for some time, and then only changing it depending on the thing. In a 10 to 12 day stimulation, if you're changing the dosage 2-3 times, you don't have control of the cycle. So the markers I use is the age of the patient, the body mass index, the thyroid antibodies, the presence and absence of endometriosis, the immunological factor, the antral follicle count or the AMH. Then I look at the type of FSH I use and the receptor to start the starting dosage. In the monitoring, I look at cutoff levels of day 4 levels instead of day 6 levels. And I also correlate the endometrial blood flows and the cervical secretions as we go through the cycle. They should match. These have helped me to streamline my stimulation protocol. But one thing I can always say is there are many ways of doing things of IVF, and this is one way of doing things we do in Vizag.
Thank you, sir, for this extensive protocol on how you basically dose your patients and select the drug that you're going to use. There's one more question. We'll take that question because this is coming from Gurgaon by Dr. Shalini. How will you stimulate patients with PCOS morphology with low AMH? Normal BMI of a 30-year-old with a previous poor response with 300 HMG antag cycle, where she had only 2 embryos on day 3 and a negative pregnancy. I'll just share the screen with you, demonstrate the question.
Who is the question for?
It's Dr. Gunishila. Would you like to answer that question, please?
Yeah, but I just need I'm not able to hear it.
I can share the screen. Okay. Can you see this question? How will you stimulate patients with PCOS morphology with low AMH, normal BMI, 30-year-old? She has normal BMI. She's 30-year-old with previous poor response with a 300 HMG antag cycle, where she had only 2 embryos on day 3 and a negative pregnancy.
I would most probably start with a 2:1 again an FSH and an LH protocol. But with this kind of a patient, I know I'm going out of the whole situation, but then I would give them a very small stimulation and do an IVM, because if she's not produced enough number of I want that thing again. I want to know how many follicles she produced. I just want to know that. I want that screen again, please.
Yeah. Okay.
Yeah, she only had 2 embryos. We do not know how many follicles she produced. What was the number of, were they empty? What happened to the actual follicular count? And I would maybe go on to recombinant FSH and an LH combination with her and try again, or I would do I would most probably for her do from about day 2, day 3 start off with a 1 ampule of Gonal-F and take out the oocytes when they were immature and mature them outside. That is how I would manage this patient.
Dr. Mittal, any comments from your end?
So you know what I would do in this case? Number one, I would reconfirm my diagnosis. I would see where the AMH was done. Am I missing on a faulty AMH because of a technical issue? And if the AMH is still low with a PCOM kind of a morphology, I think number one, for me, the drug would be different this time. It could also be a drug-related issue. I would start with the recombinant FSH 225, and I will see in the cycle how she is behaving. So this is the only change what I think I would do. I will look at the diagnosis and the drug, because the patient parameters are not changing whatever they are. So we keep this in mind that AMH is low, even if she hyper responds, and definitely it will be an antagonist cycle. It will not be an agonist cycle for me in this patient. So that either ways, either if she has low response, then I was expecting it. By any chance, if she has a hyper response, then I can at least, freeze or give an agonist trigger. So if there's a confusion in the diagnosis, I will restart by checking my diagnosis.
So comments from your
Dr. would like to
Dr.
do.
Ramaraju, yes. Any comments?
First of all, a PCO with AMH 0.5 does not exist. First of all, a PCO with an AMH 0.5 does not exist. That's my comments.
So you can have PCOs with poor response. You can have PCO, with regard to the AMH, you can have PCOs who don't respond very well. The only thing is that we do not know how many follicles she had and what was her, shall we say, when they did the OPU, what exactly, we need a little bit more details, but you can actually have a PCO with a low responser.
No, what I'm saying is a PCO with a 0.5 AMH does not exist.
Yeah, okay. Yeah, that is true, but then
So
they will not respond very well.
Around PCO with very high AMH and high FSH, and they show poor response. But yes, they normally have very high AMH.
Yeah.
I agree with what you said, but I don't agree with a PCO with a 0.5 AMH.
Mm.
That's the reason I think rechecking the AMH is important, and the lab from where it was estimated.
Because what happens is, in a PCO, the number of granular cells are many, and which in turn says many follicles. If the granular cells are few, then the question of PCO might be when the diagnosis of PCO becomes a primary issue of whether it exists or not.
So with that comment, sir, if you have no other comments, I think that was the last question for this webinar series.
Yes, sir.
I want to first of all thank all the delegates who are there for about 1.5 hours and have taken out the time on a weekday in the evening for attending the webinar. So thanks a lot to all who are attending the webinar. And of course, our experts, Dr. Ramaraju, Dr. Shweta Mittal, Dr. Devika Gunashila, for making their time available on a busy weekday from the busy practice and being present for the audience and to share what their experience and knowledge are on different case studies related to AMH. And with that, we'll come up with more case studies. Or for the delegates, please don't forget to fill in the feedback form that's there in a link when you have logged in. Please fill it so we'll know as to what kind of topics that we can address in the future. So with that, I thank everybody, and any comments or any goodbyes from the experts, and we can close the seminar.
I would like to thank Dr. Pavitra and Merck. I think this is the first time that I've done a webinar, and I think it's been a very good experience, quite exciting actually, and interesting to say the least. Thank you very much.
So a big team has worked behind this. It's not only me, it's our entire team who has worked around organizing this event. And on their behalf also, I'd like to thank all of you. So thank you.
Thank you, Pavitra and the whole Merck team, and for everyone behind the screen for helping this happen very, very flawlessly. And thank you, Dr. Ramaraju and Dr. Devika. It was very nice hearing you and interacting with you. Thank you so much.
Thank you very much too.
Thank Dr. the Merck team, the team from the webinar, Amit, and my colleagues, Dr. Sweta Mittal and Gunishila. And we hope that we'll have lots of opportunities to come back and do a better job than what we did today. Today I'm happy, but we can do a much better job in future. Thank you once again for joining all of us, and it has been a very nice experience for me.
Thank you. Thank you so much.
Thank you so much. Thank you.